Good morning, good afternoon, and good evening, depending on the place where you are. My name is Dr. Gustavo Lopardo. I'm a specialist on infectious diseases, and for me, it's a great honor to welcome to all of you to this Congress held in Buenos Aires City. This is the city where I was born and where I live. I'm professor of infectious diseases at Buenos Aires University, and for me, it's a great honor to share with you this symposium titled The Effect of COVID-19 on the Elderly Population and the Impact of the Vaccination. We will see in the next slide the objectives of this symposium, that will be to provide the burden of disease in the elderly population during the pandemic. Then, Dr. Amaggi will describe the impact of the vaccination, not only coming from the randomized clinical trial, but also coming from real-world evidence. And finally, we will have a roundtable discussion, included also Dr. Alexandru Calace. And at the end, we will invite you to questions. Let me introduce my colleagues and other speaker, Dr. Stefania Maggi. She is from Padua, Italy, and she's research director of the Asian branch at the CNRIM. And from Brazil, Dr. Alexandru Calace. He is the current president of the International Longevity Center in Brazil and co-director of Age Friendly Institute in Boston. And let me share with you the agenda in the next slide. This is my welcome, then I will briefly update the current numbers of the pandemic, and then, as I mentioned before, Dr. Amaggi will talk about the vaccination. And finally, we will all share a roundtable discussion, and we will invite you, as you can see in the next slide, to send us questions. In that slide, you can see that in the box located below the screen, you can send us the questions. In the next slides, you can see some relevant information. As you all know, this meeting is sponsored by Pfizer. We all receive honoraria, and those attending to this symposium will not be able to earn CE credits. In the next slide, you can see our disclosures. And let me start with my first talk. I will talk about the numbers that tell us the story. That means that we will share which is the current status of the pandemic and what happened during these 2 years and a half. Next slide, we will see, again, mass disclosure, but in the next slide, you can see the current data that were updated yesterday. So far, more than 535 million cases were notified. But of course, we all know that it's not easy to test all who are positive, those who are symptomatic with mild diseases, and of course, depending on the testing capacity of the country and of the healthcare system. So many experts consider that probably more than 50% of the world population has already been infected with SARS-CoV-2, and probably many of them have also suffered reinfection. In the middle of the slide, you can see the number of deaths that currently is above 6.3 million deaths. But of course, it's very difficult to be able to notify all deaths. And currently, we are reviewing the definition. In 2022, all patients who die with a COVID test positive, do they die because of COVID? So probably it's considered by WHO that during the first 2 years of pandemic, the excess mortality was more than that and was probably 15 million deaths. And on the right of the slide, you show good news. It was really from someone who's a specialist on infectious diseases, really very focused on vaccine, particularly for the adults. It was incredible for us that at the end of the first year of the pandemic, the first vaccine were available. And you can see 11 billion doses have been already applied. That represents about 1.5 doses per habitant. However, we are all aware that the distribution of those doses shows a very clear inequity that we will talk later on. In the next slide, you can see figures from the case fatality ratio. Remember, at the beginning of the pandemic, when we received news from France with a high case fatality ratio compared to Germany with lower. But of course, as you can see in the slide, that depends on the testing capacity. The more you test, the lower the case fatality ratio. Also, case fatality ratio will be associated with demographic. Older population with a higher prevalence of comorbidity would be a higher risk of death. And finally, the features of the healthcare system. I remember in my country, in Argentina, at the beginning of the pandemic, a strict lockdown was established. One of the main objectives of the lockdown was to improve the quality of the healthcare system. In the next slide, you can see data from the United States. This was a retrospective observational study performed in 2020. Look on the left. At the beginning of the pandemic in the United States, the hospital mortality rate was almost 20%, 19.7. And only 7 months later, in November, was 9.3. The authors of this study were not able to analyze which were the reasons for the decreasing mortality, but probably all of us, we agree that we improve the quality of care, the quality of ventilating patients. We learn the relevance of the prone position, of stereos, or some other tools that were implemented. Of course, mortality rate must be adjusted for age and depends also on the testing capacity. In the next slide, we can see data from CDC that show the data from the United States. And you can see here, you can see from 2020, 2021, and 2022. The start of 2022 is very easy to realize because the high peak of Omicron, remember that Omicron is the second most transmissible virus after measles. And you can see that these are a number of cases. In green, in yellow, the solid and the dashed lane represent the very young, the blue or green represent the middle age, and the purple represent those 75 plus, at a lower percentage. And in the next slide, what you can see is the hospitalization rate according to the age group. And you can see that those 65 plus were at the highest risk. And in the next slide, what you can see is the comparison of what I showed you at the beginning, analyzing the case rate, and on the right, the death rate, definitely higher for those 75 plus. We are all aware, of course, of this. In the next slide, I will share with you some data from my country, from Argentina, very similar to those data, analyzing in the blue bar, the first year of the pandemic, orange 2021, and the green one is the current year, showing the highest incidence of cases in middle-aged subjects. However, in the next slide, you can see that the mortality and the death was associated with age. As you can see, about 70% of death occur in those 70 plus and 85% in those 60 plus. In the next slides, these are data also from Argentina, my country, showing the relevance of comorbidities. There was an analysis of 65,000 deaths. And as you can see, in the first bar, for example, hypertension, the dark blue bar represents those age more 60 and plus with hypertension who died. And the light blue bar represents those less than 50 who died, clearly showing the high relevance of different comorbidities, including hypertension, diabetes, obesity, and heart failure in the risk of death. This next slide shows data from Europe. And this is analysis conducted in several countries, but mainly in France. At the very early pandemic, look at that, February 25th, 2020, till May of the same year. And what we can see in that very elegant graphic is that the mortality, the 90-day mortality, was highest in those who were 80 or 85 plus, but also associated to the clinical frailty scale, something we are all very familiar with, introducing the concept that not only age is a clear determinant of the death. The data of the next slide are really very interesting to share with you. This study was conducted in Sweden, and I like it. Look at this. They analyzed the excess mortality compared to the previous year, 2015, 16, and 19, and they analyzed the first month of the pandemic, April to June 2020. On the left side are women. Please look at the second bar. You can see there is a black line and the dot is in 1.4. That represents that in that age group between 75 and 79, the excess mortality was 1.4, meaning 40% higher. It was not the same for all these women. In the lower place of the bar, the dark blue represent those who were 75 to 79 but were independent living, and the excess mortality rate was only 6%. In the blue, that above that, were the same group that were at home care, and in the light blue, were in a care home, really reflecting the relevance that not only age is associated with COVID-19 death, risk of death, but all the health stages. In the next slide, you can see data from my country again, and you can see here the red color represent the rate of death per million individuals, and you can see above is 80 plus, 90 plus is clear, and you can see it's very clear how you can see the different ways. On the right, of course, Omicron way, the most recent way we are all suffering. In the next slide, we are going back to United States data, and this is also very interesting, and these are data really updated. We can see in the first row, cases, in the second one, hospitalization, and in the third one, death. They consider that the reference group was those aged between 18 and 29. And as you can see, the incidence is very similar in different age groups, only lower in toddlers, those below 4 years. The hospitalization rate compared to this very young age group between 18 and 20 now increases after 50, 65, or 75 years. You can see 8 or 10 times. But look at the death rate. In those who were aged between 50 and 64 was 25 times higher. And in those 85 plus were 330 times higher. Really a very relevant, important of age in this group. Also with comorbidities, as we mentioned before. And this slide, the next one, that is probably my last slide, is to introduce Dr. Stefania Manche Tokta. She will talk about vaccine, particularly in the elderly people. As I mentioned before, distribution vaccine were unfortunately unequal. And you can see several countries in Africa with a fully vaccinated percentage of people less than 10%. These are data from the United States that you can see that currently 66.8% of the total population has been fully vaccinated, and 47 has already received one booster. But what is relevant that you can see there that those 65 plus were fully vaccinated in more than 90%, and they received a booster in almost 70%. I think that this reflects the population understood that those who were elder were at higher risk. In my last slide, I will summarize several conclusions, and I think we have shared that mortality rates differ among different countries, depend of the testing capability, the healthcare system features, of course. That the risk of hospitalization and death increases with age, but also with comorbidities and with frailty status. And probably those receiving care at home, those who have a health status, a lower health status, are at a very high risk of death. So I finish here, and I will give the podium to Dr. Stefania Masci, and she will talk about the impact of vaccination.
Thank you very much, Gustavo. Your presentation underlined very well the impact of and the burden of this disease on older population in particular, and therefore I will next, please. Next. I will focus on what we really expect from a vaccine in order to be efficacious. What we expect is indeed not only the ability to prevent the disease, but also to prevent all the negative outcomes that you focus on, such as hospitalization, ICU admissions, and preventing death. But of course, the ability of a vaccine to prevent these negative outcomes depends also from the rate of transmissions and from other personal protective equipment, such as we have seen very well, working extremely well also during this pandemic, and the individual risk factors, as you underlined very well, not only age, but also comorbidities and frailty are definitely major determinants of negative outcomes. Next. Next, please. And the vaccine that we will focus on, that has been firstly made available to the international community, is the Pfizer-BNT vaccine, which is offered in the primary course with 2 doses delivered 3 weeks apart, and also for immunocompromised people, for older people, indeed a booster dose after around 28 days. This might vary from one country to the other, but usually the indication is at least 28 days after the second dose is made available. And next, please. In the pivotal trial, we have seen that the vaccine efficacy was indeed extremely high, and therefore it was really welcome during the pandemic. At the early stages, it had efficacy in the overall population of about 95%, and you see that it was very similar, overlapping with the efficacy in the older adults. And this is very important because usually we expect a lower efficacy in older individuals due to immunosenescence. Next, please. And also data on the safety profile for this mRNA vaccine was really excellent. Their reactions were usually mild or moderate, and mainly referred by the patients as a sense of fatigue, headache, myalgia, or some pain in the injection site. And after having distributed more than 3.5 billion doses internationally, the results of this safety profile have been confirmed, and therefore it's a very safe vaccine. Next, please. But of course, there are special warning. For example, we know that there might be cases of hypersensitivity or anaphylaxis, and this is why we ask patients to wait at least 15 minutes after being vaccinated, just to see if there are any need of intervention for anaphylaxis. And also, you surely have heard about some complications referred to myocarditis and pericarditis with mRNA vaccines. But this is mainly reported, in most cases, in younger males. And it doesn't really affect the target populations that we are addressing today, being the older population. Anyway, of course, the healthcare professionals have to be careful in making the patient aware of the fact that any symptoms that might suggest one of these diseases, such as chest pain, shortness of breath, or palpitation, should be referred to physicians, of course. Next, please. And going from the efficacy data in the pivotal trial to the real-world data, we see that the effectiveness of the vaccine was maintained very high. These are data from a meta-analysis that has been recently published. And you can see that the effectiveness was about more than 91% in the general population, and about 84% in the older individuals. So therefore, still maintained very high, also in the real world. Next, please. And what was really impressive was the fact that the high vaccine effectiveness against the COVID-19 was maintained across age group in preventing hospitalization, severe disease, and also death, without differences across age groups. And this was provided by the national program of Israel during the alpha predominant period, because you know that we had several variants following the alpha predominant period. Next, please, and we will see the impact. Again, the other point that I like to underline is that even in the oldest old, above 80, 85, 90 years, the vaccine efficacy was still very high, from 68% in preventing the infection to 73 and above 73 in preventing hospitalization, and above 85% effectiveness in preventing mortality. So definitely the 2 doses of Pfizer BNT vaccine had a very high effectiveness in the real world, in the population also of the oldest old. And as we will see in the next one, very relevant also in the most vulnerable subsegment of the older population, those living in the nursing home, therefore with more comorbidity, frailty, and disability. Indeed, during the alpha predominant period, we have shown an effectiveness of more than 95% in reducing hospitalization and death among nursing home residents, therefore similar to the pivotal trials that we have seen at the beginning of the presentation. Next, please. But unfortunately, we have also studies confirming this data, meaning that after 6 months from the second dose, during the Delta predominant period, we have seen a waning of the immunity across all age groups. And if you focus on the age plus, 60 plus, you see that the waning was very, very important. Therefore, The question is, was it because of the Delta escape of the vaccine efficacy, or was it because there is a natural waning of the immunity with time? Next, please. And this, I think, shows very well that indeed the waning seems to be primarily driven by the reduction over time of the efficacy of the vaccine, because we see the decline not only for the Delta, even if it was slightly higher, the loss of immunity compared to the other variants, but you see that it is a common trend of decline in immunogenicity. Next, please. And therefore, the booster dose was suggested. And again, Israel started with providing the booster to the population over 60 years of age. And as you can see, the rates of infection had about a factor rate ratio of 11, comparing the booster versus the non-booster, and of 20 lower rate ratio compared to those non-booster. So high efficacy of the booster dose after 6 months in preventing infection and severe illness. Next, please. And this shows that it was across all age group, even among the younger cohort, that we, with the booster dose, we were able to show an important decline in the incidence of the infections after the booster dose. Again, these are data coming from Israel. And after more than 7 days after the booster dose, there was actually an effectiveness of declining the severe disease of 92%, declining death rate of 81%, and overall in the population 40 to 69, decline and effectiveness of 94% in the severe disease. Next, please. And this is just to confirm, and I think these data are extremely impressive, because during the study period, a large proportion of 60 years received the booster, and this led to a substantial decline in the overall incidence of the infections. When you look on the right part of the slide, you see that when the population, older individuals have reached a high percentage of vaccination, there was a very important and significant declines in the incidence after the general population was also vaccinated with the third dose. Next, please. And indeed, if you look at the humoral response to the third dose of the COVID-19 mRNA vaccine in older individuals, while after the, on the left side, you can see after 1 month, after the second dose, after 2, 3, up to 6 months, the response among the older individuals was always lower compared to the healthcare workers. So a decreased humoral response for the older population. But immediately after the third dose, in this population, you see that there was a very high response, and there was not significant difference between older individuals and healthcare workers, therefore the healthy younger adults. Next, please. But again, the data coming from Finland that have been also confirmed in other studies the third vaccination induced after a couple of months after the booster dose, we see a weaker immune response among older individuals, and in particular with the Omicron variant, some of the older individuals did not have any antibody reaction. So this again underlined the fact that older individuals and with specific variants do not have an appropriate defense by the booster. Next, please. So to summarize, I think that it is clear that the data from the pre-Omicron period have shown the effectiveness of the vaccine against hospitalization, and this protection remained high until 6 months after the 2 doses. Then we have seen the waning immunity, and that was observed across all age groups. Older adults mount less durable humoral response to the 2 doses of COVID-19 mRNA vaccines compared to the younger adults, but initially a strong response to the 3rd dose. And in Israel, where, as you know, the national program of vaccination was carried out, a larger proportion of the over 60 have received the booster dose, and this has decreased the infections rate and the severe disease, as it was very clear from the data I have shown. But the real-world evidence from the Ministry of Health of Israel revealed that no new safety concerns also in adults with the 3rd dose, and actually even the minor adverse event rates that were reported were lower after the post-dose 3 compared to those in the primary course of 1st and 2nd dose. Thank you very much for your attention.
Hello again. Thank you, Dr. Amashi, for your nice overview of the real world, particularly of the real world data. So we have more than 20 minutes for the roundtable discussion. And I want to start thinking about we really all suffer during this 2.5 years pandemic, and particularly elderly people were one of the groups that suffered the most. They were really vulnerable. So my question would be for Dr. Kalachi, that I want to welcome him to join right now for the roundtable discussion. What do you consider that were the biggest achievements and failures? Because we were learning day by day by mass. What were the biggest achievements during the pandemic?
Well, first of all, my greetings to you all, and my thanks for the invitation to speak at this symposium. You have already, Gustavo and Stefania, provided a very good background. But it's obvious that the biggest achievement that we have seen with COVID was, as you have pointed out, Gustavo, in a very short period of time to come up with not one, but several vaccines. This is a triumph of modern science. But we have to focus on all those people, which is the opposite face of the achievement. All these people throughout the world that have been left behind. And if there is a lesson that we should take very seriously from what we have seen with COVID, is that inequality kills, and has killed hundreds of thousands, if not millions of people. But mortality is one way to measure the impact of COVID. We also have to pay attention to those that were traumatized, and we can expand this if the time allows, because we are not dealing with a pandemic. It's a syndemic, a convergence of different crises that is also socioeconomic, biological, environmental, and for sure, loneliness of all those people that have survived their dear ones.
Thank you, Dr. Galache. Dr. Mashi, would you like to add some comment to Dr. Galache's comments?
Well, I fully agree that the main achievement was indeed to have the vaccine so quickly available, and they were effective, safe, and this was the result really of a common effort of public and private sectors. And also it was very important, in my opinion, to have data available very soon so that we could monitor the epidemiology of the disease across the world and across a subgroup. And as Alex said, I think that the upsetting thing is the fact that a health emergency has become also a socio-economical emergency due to the different and inequality that the world had to face in these circumstances.
Thank you. I think that probably one of the main challenges that we are facing right now is how to distribute the vaccines in a better way, definitely. In America, for example, Guatemala, only 37% of people fully vaccinated. And in Africa, as mentioned before, very low coverage. And let me share with you, as especially on infectious diseases, that where the virus replicates the most, the risk of new variants of concern is higher. Remember that the last one, Omicron, came from South Africa last November, and now we have sublineage. But we must really, because many reasons, to have a better distribution of vaccine. So thinking about all this comment, I will go to the second topic that will be of what we have done, what worked and we didn't. We say that vaccines work. What worked and we didn't work, Dr. Alex?
What has not worked, Gustavo, is the complacency. I'm here in London. I have been to Boston, Chicago, New York over the last month, as well as São Paulo and Rio. It's just like it has not happened. You don't see people wearing masks. It's over. Let us celebrate. And this complacency we are seeing also, not only in my country, but here in London. Again, a surge of cases, and people don't care. On the other hand, it's not only the poor countries that have not been vaccinated. We have bubbles within developed countries with access to vaccines. But for whatever reason, it could be ideological, it could be healthy literacy. The reality is that they are not getting the vaccine. But we are in the same boat. In the same way that we live in a globalized world and variants can come from Africa, they can also come from the next neighborhood, which is black, which is poor, with illegal immigrants. And these people can brew new variants next door. And because we have become complacent, we are not learning the lessons that COVID has brought to us.
Totally agree. So my next question to any of you will be, during the pandemic, the pandemic has a lot of impact in the public health. Some impact will be direct, some will be indirect. Which do you think will be this impact for the future in the public health?
Stefania.
Well, I think we have to think about the direct and indirect impact that we had with the pandemic. I mean, the indirect consequences was the fact that we had really not only the effect of the pandemic in the most vulnerable, in older individuals living in nursing home, being the subgroup with the highest rate of hospitalization, of mortality, and therefore nursing home became like incubators of the infections, particularly at the early stages. But we had also all the indirect impact in public health because of the missing preventative measure for example, other vaccination. We had a decline, disruption in the delivery of the usual vaccines at any age during the life course. We had the missing check-up for people with chronic diseases, and again, the older individuals were the most affected. Plus, as Alex was mentioning, I think that as geriatricians, we are very, very sensitive to the global health and well-being of older individuals. And when people were kept in nursing home, isolated, they couldn't see their family members, they couldn't see anyone. I remember always what was said by my friend, a geriatrician from the Brown University, who said the United Nations consider a torture if you don't allow a prisoner to see people for more than 15 days. So we can really say, although we didn't have any alternative at the point, that we have tortured older people by keeping them isolated and at high risk of depression, and therefore of all the complications of isolation, depression, cardiovascular disease. And I think that this is a lesson that we really have to learn for the next, for the future.
Alex, any comment?
Yes, my comment is that all the data and all the reflections that Stefania has made applies to us in the developing world. But there is a complication factor here. And the complication is poverty. And we have increased the poverty. We have increased the number by millions of people that have fallen below the poverty line. I'm coming from a country like Brazil, where now 56% of the population lives with food insecurity. COVID has aggravated not only the poverty inequality, but also access to basic things. And we are a very rich country. We have been, over the last 10 years, number 1, 2, or 3 most important food producer in the world. It is catastrophic what has happened. But in addition to that, we have something that we have not touched, and it's complex, and it's called ageism. Because a lot of what has happened is because older people don't count. They have already lived. If they are frail, if they have comorbidities, and comorbidities in developing countries, you don't have to wait until you are 70 or 80. Because of the life course of inequalities, lack of access to services, you may be 55 or 50, already have the comorbidities that will make somebody old at 8 in Sweden, but old in Africa, in Latin America, at 55. And all these lessons have to be taken seriously.
Totally agree, Alex. Yes, and I think that also one of indirect impact of the COVID pandemic was the lower coverage in vaccination in general, in all ages. So I hope that we have to work on improved vaccine coverage. And one thing that could be good for the future, I hope that probably the whole population understood that vaccines are not only for children. We have vaccine for all ages, for children, pregnant women, young people with some comorbidities, and particularly also the vaccination of the elderly is so relevant. We will see in the future what happens with these concepts.
But Stefania is already showing, she has already mentioned that coverage for other vaccines, instead of going up, they have come down. It is inadmissible, for instance, that people are still dying at whatever age, but particularly in old age, because the incidence is so much higher, of pneumonia, if we have a vaccine that is not being used, and other diseases that we can prevent through vaccination. So we need to have health literacy from the decision makers. All these vaccines are not going to be made available to the population, although they exist.
Yeah, and I think that it would be very important, I think, a position from international agencies such as WHO and so to insist that all countries have lifelong vaccination schedule and not, be segmented for children, but just to start thinking about the relevance of a lifelong approach, because it's the only way that would create the culture and the sensitivity of what really vaccinations means. That is not just preventing the acute infections, but it is really a way to promote health at any age and to promote healthy aging in particular.
Okay, I will go to another topic. And let me talk about something that I'm sure you know both about, that is ageism. From the beginning of the pandemic, the whole community was aware that COVID was really hitting the old people, particularly nursing homes in Europe. I remember February 2020 in Italy, Spain, Belgium, France, indeed. So probably after that, probably ageism has been a factor in dealing with the pandemic. And so I want to know your opinion, which was the relevance of ageism in the way we deal with this pandemic.
Sorry, could you repeat the question, Gustavo? It's a bit broken.
Yes, I know. The idea is, in your opinion, has ageism been a factor in dealing with the pandemic in your country or in your region, and how we can deal with that?
Well, in my opinion, we are faced with a pandemic of ageism, and we have to face it seriously, because if this most important social achievement of the last 100 years was to be able to get older, just think that in 1900, the highest life expectancy in the world was in Germany, 46. There is not a single country with such a low life expectancy, even in the poorest countries in Africa. Well, if the social achievement of the 20th century was to be able to age, the biggest challenge of the 21st century is to respond to this longevity revolution. And we are, by and large, failing, because we continue to see old people as recyclable, disposable. They have nothing to contribute. The message is clear, be it access to services, to education, to jobs, and the role of older people in society. And yet, for instance, in my country, the poorer families that were lucky enough to have an older person during the COVID, because this older person had a regular income, was protected from acute hunger. There was somebody that could pay the internet, the electricity for these grandchildren to eat and to study.
Yeah.
Stefania, an European perspective?
From the European perspective, I think that we have learned an unbelievable lesson during the pandemic against aging, because if we didn't have retired physicians, retired nurses, retired social workers who would volunteer to go back to work, our systems would have really collapsed. And I think that this is really a lesson that older people are not, as Alex said, the garbage of the society, but they are a pillar of our society and they are instrumental. So this has to be taken into account for sure.
Okay, thank you so much. So to finish with this roundtable session and to receive some questions from the audience, we're still suffering after 2 years and a half of pandemic. For sure, we should have learned. So some reflection for future pandemics. Nowadays, we are still suffering the reemergence of a new disease, monkeypox fever. So what did we learn from COVID pandemic that can help us for future pandemics? Alex?
My opinion what we are not taking seriously is that the environment is fragile. We have COVID today. This could be a rehearsal to other pandemics or the virus, the way we are treating Mother Earth. Mother Earth is telling us very clearly, I have a commitment to life, not necessarily to human lives. And if you continue to behave the way you are, if you continue to set on fire the Amazon and disrespect the environment, I will just launch new viruses. And you human beings can go. Life will continue.
Thank you, Alex. Stefania?
Yeah, I agree. This One Health approach is really to be taken serious. And usually when I speak about aging, I speak about the role of diet and the impact of diet also on the environment and the pollution impact on the health of older people. And this become a vicious cycle that really affect the overall health of the planet. So this for sure is a lesson that we have learned. And the other one that as a geriatrician, I feel allowed to say is that we geriatricians should take a bit of responsibility for not having created among other doctors and specialists the culture of the fact that age is not a criteria for deciding what to do. And at the beginning here in Italy, for example, when the intensive care units were absolutely and leaving to the doctor the choice of should I admit the young or should I admit the old was based, unfortunately, on the age criteria. So we should be more sensitive to the fact that we have to speak more about the role of comorbidity, about the role of other indicators, and age per se cannot be a criteria that is used in this.
If I could just add, Stefania, the 14 years that I was the director of the WHO Department on Aging and Health, this was the most important challenge because our colleagues don't listen.
Yeah, but probably we should speak up more often, I think.
I'm getting hoarse for shouting.
Definitely, I agree with you that we must work all together to face new viruses, new diseases, new pandemic. Remember that SARS-CoV-2 started in Asia. Monkeypox fever, the Nostalgia came from Africa. And when we analyze the variant of concern, they came from many different countries of the world. The only way to face this situation is to work all together. We have one question for Dr. Maggi from the audience. And the question is, there are some adverse effects regarding cardiac system. Can this arrhythmogenic potentially accelerate cardiac chronic disease?
I'm sorry, I didn't understand.
Yes, well, the question is regarding the risk of arrhythmogenic that the vaccine may have. Is this arrhythmogenic potentially accelerate cardiac chronic diseases?
Yeah, well, I think that as we have seen with the infection, an increased risk of cardiac effect, of fibrosis, of myocarditis, we expect to see something also from the vaccine. And we did see, I mentioned briefly in one of my slides, what is of relevance is the fact that the pericarditis and myocarditis that have been reported, they were usually more frequent in younger adults and in particularly younger men, not in the older individuals. And overall, of course, the risk of these complications is much, much higher in the population who are unvaccinated and affected by the disease compared to the vaccinated population at any age.
Definitely, I totally agree. Always the risk of most adverse events exceed the risk with the disease compared to the risk of the vaccine. And I have another question here. Good morning. My name is Dr. Jorge Mendoza Machicado. Excellent presentation. My question is if there is data on the application of the vaccine for COVID and at the same time the vaccine for influenza. If there was any type of reaction due to this application together. So the question is regarding the co-administration of COVID vaccine and influenza, Stefania.
Yeah, I think it's a very, very important question because when we speak about the low coverage of vaccine and vaccine hesitancy, one of the strategy would be to co-administer is given in one arm and the other in the other arms, not in the same place. But there are also evidence of not decreased immunogenicity by administering influenza and COVID vaccine together.
Always the co-administration is a good health policy because we increase the acceptance of vaccine. Even a co-formulated vaccine of COVID, RSV, and influenza is being tested in different studies, but so far, of course, not available. I think we are reaching to the end. I don't know if you have any final comment. When you are thinking about the final comment, I will ask all the attendees to remind that if we ask you to submit the variance and the evaluation at the end of the session. But probably, Alexander, any final comment to wrap up the meeting?
My final comment is insisting again, we should not measure the suffering throughout the world by the number of deaths. We have left millions of people traumatized, and we have, as a result, more chronic diseases, more depression, more mental health issues, more loneliness. So let us take this seriously and take the lessons and apply them to public health.
Thank you. Thank you very much. Stefania?
Well, I'm looking forward to more data on the long COVID because I think that is on the other side another major impact that we expect, and not only in older patients. And I think it's really something that underlines again the fact that infectious diseases do not have an acute impact only, but as we have probably not given enough attention to the long impact of other infectious diseases, such as influenza, such as many others respiratory diseases, and this is an occasion to pay more attention to infectious diseases at any age, but in particular in the older population.
Definitely, probably prolonged COVID, on sequelas of COVID are currently very relevant, and probably one of the new endpoints of the vaccine studies should be how do they prevent the sequelas or long COVID. I think that would be really, really very interesting. Well, we must wrap up. We review which was the impact of COVID-19 in the elderly. Dr. Amashi also shared with us which was the data coming from randomized clinical trial, and particularly the real way data showing the high efficacy among all age people, including the elderly. And we have had, I think, a very nice discussion analyzing different topics, which was the impact of this pandemic in all age group, particularly in the elderly. I encourage everyone who is attending this session, please send the evaluation. And so I want to thank Pfizer for inviting us to share this time with you. I hope this time you can come from Brazil and from Italy to Buenos Aires, but I really enjoyed this meeting. Thank you, Alex. Thank you, Stefania. And thank you to all of you.
Thank you.